Thank you so much, Dr. Rymack and distinguished colleagues and honored guests who are here today. It is truly an honor to be receiving this acknowledgement of my work today. Although I'm not a Western alumnus, I have spent my entire academic career actually here in the School of Nursing. And so I see Western as my academic home. It's a place where I have found tremendous opportunity and support over the years. And I want to acknowledge that my husband Steve and my daughter Sarah, are here today. And our son Matt would be here, but he's finishing exams, as lots of students are these days. They each have very busy and accomplished lives on their own, but they've always been very respectful and supportive of my career. And I think they learned pretty early on, as some of your families may know too, to give us a little space around things like grant deadlines. For that and for many other things, I'm very grateful to them. I've also had the privilege of working alongside an amazing group of colleagues, partners, and graduate students over the years, some of whom are here today, and actually many of whom are here today. Too many almost to mention, but I'll point out Nadine Wathen and Vicki Smythe, Helene Berman, Joanne Hammerton, Research Manager Extraordinaire, Tara Mantler, Yvette Lafayette-Fleeser, and many others. And some who are not here today, they're here in spirit. The really close colleagues that I have in other universities, particularly Colleen Varco, Judy Wiest, and Kelly Scott Story. Now, they have, of course, strengthened and enriched the academic work we've done together. But truthfully, their friendships have made the process personally meaningful to me as well. So research has always been a central focus of my career for the past 25 years, and all of that work, every single study, has been conducted in a team. The primary focus of this work, as you've heard, has been about women's experiences of intimate partner violence and the impacts on their health and lives. And in this time, I've come to appreciate the strength and adaptability of these women. So like the willow that you'll see behind me, these women may appear delicate and fragile on the outside, but many have very deep roots that bind them to the ground, and also branches that are flexible enough to bend in the wind. But they're not invincible. And like the willow, they can survive drought for a period of time, and maybe even a storm or two. But they need a nurturing environment to grow and thrive. And as a nurse researcher, my challenge really has been to identify how we might help these women find their strength. In other words, by developing and mobilizing knowledge to inform services and policies that support women's safety and healing. Now, I have to tell you, when I started down this path, intimate partner violence, or IPV that I'll refer to, it was called mostly domestic violence at that time, was still largely seen to be a private family matter. And think now, many years later, we're in an era of Me Too, of the National Inquiry on Missing and Murdered Indigenous Women, and public debate around things like human trafficking. And federal investment in research and programming related to gender-based violence is unprecedented now. Even locally, if you're watching the media, last week I saw that the London City Council is considering adding a focus on violence against women as one of its policy priorities for the next year, really at the urging of some very persuasive local agencies. So violence against women is clearly on the radar globally, nationally, and internationally. We now understand that intimate partner violence, so a pattern of physical, sexual, and psychological violence, including coercive and controlling behaviors, is both a human rights and a public health problem, and it's something that occurs at alarmingly high rates. So we know that globally and in Canada, 1 in 3 women experience IPV in their lifetimes. And because violence contributes to health, economic, and social inequities for women and girls, the United Nations has identified its elimination as a critical goal in achieving gender equality, and also in creating more stable and sustainable communities on a global scale. So while some of the shifts I've been talking about are certainly signs of progress, and we've come a long way, there's still a long way to go. And I'd say particularly in healthcare, where there's such great potential for impact, and yet little evidence around how to actually effectively address IPV in practice. Now, as you might expect from what I've said so far, For me, research has never been about a purely academic exercise, but it's been looking at it as a powerful tool for both understanding the complexity of violence and from that developing meaningful practice and policy solutions. IPV is one of those wicked problems of the day. Unfortunately, there isn't a simple solution. It's multifaceted, it touches many aspects of women's lives and even different systems. So we think about legal, social, economic, and health systems, for example. And women experience it also in different ways, in part because the unique conditions of women's lives affect their risk, it affects their options for seeking help, and it affects how they experience that process as well. So although it's a common experience, it is actually something that is quite often invisible. As a novice researcher, it was certainly invisible to me. And many years ago now, when I started my dissertation work, it was actually a study that focused on the strengths of single-parent families, a topic that was motivated by my experience as a public health nurse. My supervisor was Dr. Jackie Campbell, who's a renowned scholar in the area of violence against women. And as a good mentor, she encouraged me to ask the women in my study about their experiences of violence and trauma. And as a bit of a headstrong student, I dismissed her suggestion, of course. But in the first study that I did after I finished my PhD, it was a study of 280 single mothers who I recruited from the community. I took her advice, and I asked a few questions about their histories of partner violence, at the end of the demographic questionnaire. Well, the women in this study had been separated an average of 80 years. And not only did they report living with a wide range of chronic health problems, but the majority of them, between 55 and 88%, had also experienced partner violence. And this is what led to that separation. It was an aha moment for me and a real turning point, because I understood then that the single mothers who I had been so interested in were actually women who had successfully left abusive partners, and they were living with the aftermath of abuse. It was a reminder, I think, of our tendency to put people in silos rather than to think about how their lives are connected. So in the decade that followed, we conducted a series of studies to try to understand what was actually going on with these women, both in terms of their lives and their health. And the first study was conducted with Judy Wiest, Helene Berman, and Marilyn Merritt-Gray. And it was one of the first qualitative studies actually funded by the Medical Research Council of Canada. We learned in that study that women were determined to create a better life for themselves and for their children, and that regaining control over their lives is an important part of the process. They worked hard to do things like getting basic needs met, rebuild support systems, stay safe, and even begin healing from the abuse. But intrusion, external interference that came from ongoing abuse, health problems, changing or unstable living conditions, and even the costs of seeking help got in the way. And it really robbed these women of the control that they were seeking. From this work, we reasoned that interventions built around women's priorities and that might actually help them focus on reducing that intrusion could actually be helpful to their health and quality of life. Now, I'll say also that over the years, we've benefited from ongoing funding from the Canadian Institutes of Health Research, including a new emerging team grant focused on the health effects of violence that I co-led with Colleen Varco and Judy Wiest. And in that work, we pulled together a large interdisciplinary team of established a long-term collaboration between the University of British Columbia, Western, and the University of New Brunswick. And it's actually a collaboration that still exists today. One of the key studies we did examined changes in women's health, resources, and experiences of violence after separation. And we followed just over 300 women over a 4-year period. Now, although the average age of women in this study was only 39, they experienced high rates of all kinds of health problems, everything from depression to traumatic stress, disabling chronic pain, and neurological problems, for example, and also significant economic hardship, both of which were linked to their lifetime experiences of violence. And while the women's mental health in this study did improve over time, the levels of depression and traumatic stress, even at the end of the study, were still concerning. And their poor physical health didn't change at all. So they were accessing, though, lots of services. So between their rates of service use across all kinds of sectors was between 2 and 292 times higher than that of Canadian women in general. And the estimated cost of that was $6.9 billion annually. And in spite of all of that, they still faced access barriers like waiting lists, no services or transportation challenges, particularly for women living in rural communities. And they often reported that the services actually didn't meet their needs. The systems, I think, were failing to provide that nurturing environment that I talked about in spite of the high costs. And it suggested that we need to really rethink how we provide services to women with histories of violence, and to think about this as an across-sector issue, since their needs for support were broad and often very linked. So, what does that mean about how we might strengthen services for these women? Well, we've been trying to address this question using two related approaches. The first is a general approach for strengthening healthcare, and the second is really testing interventions specifically developed for women who've experienced violence. So that first strategy is really about promoting trauma and violence-informed care in all services, and not only in healthcare. This is a universal approach that focuses on creating safe environments for people who have experienced and might still be experiencing violence and trauma. And like trauma-informed care, which might be a familiar concept to many in the room, it recognizes that people's responses to violence and trauma are really expected reactions to sometimes horrific and very threatening events. But it's not about what's wrong with the person, it's about what happened to them. However, what the V does in trauma and violence-informed care is it reinforces the idea that systems and services can also actually perpetrate violence, most often unknowingly, but with harmful effects. So this can happen, for example, when people or policies reinforce stereotypes or biases, or they fail to consider people's histories and social conditions when we're delivering care. As a component of equity-oriented care, trauma and violence-informed care emphasizes then taking steps to make services in any sector as comfortable, respectful, and inclusive as possible, and to adopt approaches that focus on choice, collaboration, and connection. Now, trauma and violence-informed care is something that's getting a lot of attention as a promising practice, both nationally and internationally. And our work in this area really stemmed from CIHR-funded study that was done in primary healthcare settings called Equip Primary Healthcare. We did this with clinics in both Ontario and BC that were serving people living in the most difficult of conditions. And in that study, we found that these clinics adopted practical, low-cost strategies to actually shift their practices and policies, and that this actually had benefits for patient health. So when care was more equity-oriented, patients reported being more comfortable and confident in the care they received, more confident then in their own ability to manage health problems, and over time this translated into better health outcomes, particularly a reduction in symptoms of depression, PTSD, and chronic pain. And this is particularly important when you think about the populations that we were working with. The staff, though, importantly also said that they benefited from integrating these approaches, particularly that they found there was a better alignment of their care with the values that they held. And of course, organizational leadership is key to any kind of sustainability in this model. So while the goal of trauma and violence-informed care is to improve the safety and comfort of people who've experienced violence, this approach most likely benefits everyone. Who wouldn't want to receive services in this way? A local initiative that's combined of academic and community partners, led by Nadine Wathen, who's here, is providing considerable leadership to help organizations adopt trauma and violence-informed care in collaboration with the Center for Research on Health Equity and Social Inclusion. And I think it's a really fine example of leadership from the university and in partnership with the community. Now, the second approach recognizes that women with histories of IPV might also benefit from more specialized services, and it actually involves testing the effectiveness of interventions to improve their health, safety, and quality of life. And these interventions draw on those principles of trauma and violence-informed care I just spoke about. They use different models, but they're all designed to be inclusive and tailored to fit the particular needs of women, to recognize strengths, to encourage choice and control, and to complement existing services in local communities. And that's done intentionally so that if they're effective, there's a better chance that they could actually be adopted and integrated. And we've tested 2 such interventions in randomized controlled trials. The first intervention is called iHeal, and it's a health promotion intervention for women who have separated or taking steps to separate from an abusive partner. It's delivered actually by community health nurses over 10 to 18 visits in a 6-month period. And those nurses have completed some additional training, about 60 hours of additional training. They work with women to assist them to address their priorities in key areas that affect their health and well-being, like safety and managing symptoms. And they also help them connect to services and supports that will sustain them long-term. Now, in 3 feasibility studies that we conducted, all with CIHR funding, including one that was done with Indigenous women in British Columbia, women in these studies showed consistent improvements in their mental health, their quality of life, their confidence and control, and the chronic pain as well in one of those studies after they completed iHeal. And those changes were actually maintained 6 months later. When we interviewed the women, they told us that iHeal was safe, respectful, personal, and it helped them move forward with their lives in many different ways. So now, with the support of the Public Health Agency of Canada, we are testing the effectiveness of this intervention with 280 women living in 3 provinces in which we've been working. And half of the women are offered iHeal and the other half are offered information about community services to help them navigate on their own. Importantly, we're also studying how this particular intervention actually works for women, for whom it works, and whether it's cost effective, since these are important issues in thinking about scale up if it's effective. Now, face-to-face interventions aren't for everybody, we know that. So some women might actually be better reached by technology. And because of that, we also have developed an online safety and health intervention for women experiencing IPV. And it was tested recently in a trial of 462 Canadian women in the same 3 provinces. And this study is actually part of a global collaboration with teams in the US, New Zealand, and Australia, who tested similar interventions that had been adapted to fit their own countries. Women access this online tool through a secure password-protected website, and then they complete a series of interactive activities to help them assess their level of risk and their life priorities. And then based on how they respond to certain questions, the program delivers a personalized action plan to them with strategies and resources to help them address their safety, their health, and other needs. Now, in the trial we just finished, we were successful in reaching a diverse group of women, and they used that online tool in a variety of different ways to help them plan and seek support. Importantly, there were no evidence of harms or increased safety risks for the women. This was a big concern for the ethics board, as you might imagine. This intervention has promising impacts on women's mental health and their experiences of coercive control over a 12-month period, and specifically among women who had separated from their partners, who experienced more severe violence, who were parenting dependent children, and who lived in medium to large size cities. The women were almost universally positive that it was helpful to them in some way, and 95% of them said that they would recommend it to other women. I really like that part. I'm thinking that's the thumbs up from women. So with the promising results from this study and others, these teams in various countries are now working together to develop a common platform that will host public versions of these online tools for each country. And this is actually being done at a very modest cost through Dr. Nancy Glass's team at Johns Hopkins University, because we pooled our resources. So it's an example of working smart to be able to look at sustainability. Our main goal in all of these studies is to ensure that women have access to these tools at no cost. And with the new structure, new countries, such as Kenya and Thailand, are actually joining this group. In Canada, we actually have a partnership with the Federal Department of Women and Gender Equality to help roll out the My Plan Canada app later this fall through a new center that they announced for gender-based violence knowledge dissemination. So I have to tell you, to be at this point is very gratifying. As researchers, I think we don't always know whether the work we're doing is having any impact in the world at all. And looking back, I can see that our research has made some unique contributions in understanding and addressing the health impacts of violence in all their complexity. This has added a new dimension to well-established research programs on violence against women. Women who have experienced violence, I think, are always going to be at the center of our work, but it's really important to acknowledge that they aren't responsible for fixing the system. So continuing to focus on how new knowledge can be both useful and relevant to those who design and deliver services and set policy has to be a priority if we're ever going to create safe and supportive environments that will help all people thrive.